And the first speaker is Dr. Arti Singh. She is Associate Professor at RIO Prayagraj. He is going to present an approach to a patient of deficient posterior capsule and various surgical options.
So good morning everyone. My topic for my discussion is approach to a patient of deficient posterior capsule and surgical options. As we know, in the back posterior chamber intraocular lens implantation remains the best anatomic location for an intraocular lens. But there are causes where there is absence of capsular journal support like complicated cataract surgery, trauma and cases with big zonules. So how to proceed in these cases? We have to do the preoperative evaluation. So we have to review the prior medical records, examination of anterior and posterior segments. We have to look for vitreous prolapse in anterior chamber and examine the residual capsular journal support. So what are the surgical options? If the posterior capsular rent is small, in the bag intraocular lens is the good option. If there is significant loss of posterior capsule with intact capsulorhexis, sulcus fixated intraocular lens can be considered. And if there is no capsular journal support, anterior chamber intraocular lens, scleral fixated lens and iris fixated lens are the other options. So if the posterior capsular rent is small, in the bag implantation is always a preferred option. If it is central with a well-defined border, try to convert into the posterior capsulorhexis. That will make the tear strong and resistant to peripheral extension. Then the next is the leading haptic is first placed between the remnant of anterior and posterior capsule, and the trailing haptic then placed with the help of compression maneuver. One thing should be kept in mind that in the bag implantation should be performed in early postoperative period before the formation of anterior and posterior capsular adhesions. So if there is significant loss of posterior capsule with intact capsulorhexis, in this sulcus placement with or without capture is the best option. Here the 3-piece hydrophobic intraocular lens is always preferred as it fit better in the sulcus. While the single piece lens, which is smaller in size, usually got decentered, and its thicker haptic may cause iris chapping. And it is also better if we can do the optic capture, as it provides more stability and more centration to the sulcus fixated intraocular lens. And as we already know that these lenses are slightly anterior, so the power should be adjusted, and it nearly corresponds to 5% reduction from the predicted capsular bag IOL power. So what are the options where there is absence of capsulojonular support? The first is scleral fixated lenses. Their advantage are it can be placed if there is no capsular support, if there is no iris support. The other thing that it is away from the cornea, so the chances of corneal decompensation is less, and so this surgery can be performed in the patient of corneal endothelial diseases and also in cases of shallower anterior chamber. There are two techniques of doing scleral fixated lenses: sutured scleral fixation and sutureless scleral fixation with fibrin Yamane technique, but there is no study to prove superiority of one over the other. Drawbacks with these lenses are that these lenses are usually needs more surgical expertise, and the chances of IOL decentration and tilt is also higher in these cases. Other than that, these sutured lenses usually got through the knot erosions and late suture breakage. While the cases with the sutureless scleral fixation technique, there are chances of intraocular lens dislocation is also high. The other technique in these cases are anterior chamber intraocular lenses. The previous older design, closed loop designs, there were more chances of UGS syndromes, but with the modern open loop designs, there are less associated complications. Uh, in these lenses, risk of pupillary block is usually high, so a peripheral iodectomy is always performed, and most of the complications of ACIOL can be prevented with appropriately sized lens, but the problem is that the only limited sizes of ACIOLs are available. An overly sized lens can cause damage to angle, may form peripheral anterior synechia, and can cause more inflammation, while a small lens, which is more mobile, can cause damage to corneal endothelium. And these lenses are slightly closer to the cornea, so the risk of corneal decomposition is also very high. So these cases, in cases of corneal endothelial diseases, in cases of where there is no iris support or where there is angle abnormalities, these lenses are usually contraindicated. The next is iris fixated intraocular lens. These lenses are usually enclaved at the mid-peripheral iris, so the pupillary dilatation is usually not hampered. It can be fixed to the anterior to the iris or to the posterior to the iris. But we usually prefer the retropupillary approach because its position is more physiological. There is no need of doing peripheral iodectomy, and the lens is usually away from the cornea, so the chances of corneal decompensation is also very less. The other advantages with these lenses are there is quicker visual recovery, lower invasiveness, shorter surgical time, and shorter learning curve. The only requirement with these iris fixated lenses are that it need only 270 degree of iris tissue, and the pupil size should be smaller than 6 mm. The drawback mentioned in the literature are oval pupil, iris chafing, pigment dispersion, but in our patient we have faced very fewer of these complications. So, if there is lack of posterior capsular support, or if there is fibrosed anterior and posterior capsule, so in the back placement is difficult to do. If there is inadequate capsulojonular support, sulcus intraocular lens implantation should not be considered. If there is poor corneal endothelial health, shallower anterior chamber depth, abnormal angle, anterior chamber intraocular lens is not a good option. If there is scleral abnormalities with scleral thinning or scleritis, scleral fixation technique is not a good option. If there is inadequate iris support, if pupil is large in size, if there is uveal inflammatory disease, iris claw lenses should be done judiciously. In conclusion, careful patient selection is critical in these patients. When possible, capsular bag is always preferred, followed by sulcus implantation. But when there is no capsular support, iris fixation, ACIOL implantation, and scleral fixation are the other approach. Anatomic consideration and surgeon familiarity with the IOL technique determine the type of surgery. With lesser invasiveness, shorter surgical time, and learning curve, we found retropupillary intraocular lens a suitable option. Thank you.
Thank you, Dr. Arti Singh, for a nice